Did we all go quiet?
No, we're just getting ready to get started there. Hello, everybody. This is Mark Lynn with Healthcare Business Specialist in Chattanooga, Tennessee. We'd like to welcome you to the RHC virtual self-survey with Quad A and the compliance team. They're here with us today, and we're going to go through your clinic virtually. So that's what we're going to do. Here's my contact information. My name is Mark Lynn. I'm a CPA. I work with the Rural Health Clinic program for a lot more years than I really wanted. It's 30-something years or so. And if you need to get a hold of us, there you can. Danny Gilbert is the CPA that works with us on all these cost reports, and she will be in the background checking your questions, helping you if things go wrong. Just go into the chat and ask Danny, and hopefully she'll be able to help you. If you have questions as we go through these slides, you can ask those questions, and if Danny needs to, she'll break in and help us with our panelists with your questions as well. One reminder, we are still doing cost reports. We're up to 108 cost reports, so they're not due to July 31st, but please get them into us because we're trying to stay on target. There's all of our information of the services that we do. Because it's going to be a little bit longer session than we normally have, I won't go through and tell you all the great fantastic things we do, but there's a listing of those. If you've not become a member of our Facebook group, it's not really us, it's a bunch of great people that provide fantastic information. The RHC Information Exchange Group, we're over 1,600, almost 1,700 members now. It's basically doubled in size since COVID-19, and so many things are changing rapidly. So do join that if you haven't done so already. There will be a lot of great resources there. Again, we're very lucky today because we have wonderful panelists here with us, and so let's meet them. Kate Hill is, she's one of our superheroes. She's served in the Army, nurse, worked with TCT, inspecting clinics, is on the board of the NARHC. So Kate, why don't you give us a couple of minutes to tell us about yourself and about TCT, and then we'll move to the next panelist.
You bet. Well, first, I want to thank everybody listening to this broadcast because we really do appreciate what you do out there every day on the front lines. I talked to a clinic this morning with 97 cases in their clinic. Amazing thing. And no one sick, which is even more of a treasure. So they're doing it right. They're teaching. We really just appreciate what you're doing every day. We know this is a crazy time, and we thank you for signing in today. We are an accrediting organization. We pride ourselves on simplification. We accredit rural health clinics, patient-centered medical homes, pharmacies, DMEs. I'm sure I've forgotten something right now, but that's the biggest part of our work, and we're happy to be here today.
Thank you, Kate. And then Tom is not here with us, Tom Terranova, but he's with Quad A, and he is over, I think, over pretty much most of the organization now. And so I'll just move on to Tom. Elsie is Elsie Crawford with Quad A. She does a lot of surveys for them. I've known Elsie for more years than either one of us want to admit. And so Elsie, why don't you say a few things about yourself and about Quad A?
Well, I'm Elsie Crawford, and I've been in the field of medicine for a long, long time, and I've been participating with Quad A as a surveyor since they began in the rural health clinic world. I'm very proud to be part of Quad A and part of the rural health clinic field or world is what I say. It's a special and unique world. So we've got a great group of people, and I think we provide good service. I think we have a lot of education that we love to provide, and we look forward to continuing this for a while.
Okay, thank you, Elsie. And Elsie, are you still on the board at the National Association of Rural Health Clinics?
I'm not. I went off NARC board at the end of the year. I still serve on the Kentucky Primary Care Board and on several other boards in the nursing school in Jacksboro, but I am no longer with I'm just not on the board.
Long time. We appreciate that very, very much. So okay, Elsie, and then we'll move on to Diane Bork, and Diane is with Quad A, and she will primarily be the person that you'll be hearing from on the Quad A side. When I go through these slides today, I'll basically ask some questions about those, and we'll start off with Kate on one slide, and then Diane will chip in, and then on the next slide we'll start off with Diane, and then Kate can chip in if there's something that she's looking for. So Diane, go ahead and tell us about yourself.
Well, thank you so much for allowing me to be here today. I'm a registered nurse. I've been a facility inspector for the Ambulatory Surgery Center program for Quad A, and also an RHC inspector for a couple of AOs, I'll just say it that way. And I've had the pleasure of working with everybody here that's on the panel today. We just hope to give good information to the clinics and help them on their journeys, whatever they need, you know, as far, especially right now with the COVID pandemic. So thank you very much. And if I can help in any way, let me know.
Okay, and let's move on here. Monda Shaler is with us as well. She's the Chief Regulatory Affairs Officer for Quad A. And I didn't have a picture of Monda, so I apologize for that. But Monda, you want to say a couple words before we get started?
Sure. Thank you, Mark. I'm the shy one in the group, I guess. So I am a nurse. I have also worked at a couple of the AOs, more in the central office, and most recently worked with CMS in their central office in Baltimore, working directly with the RHC program leads and other program leads related to accreditation. So thank you again for inviting us. We look forward to it.
Okay, thank you, Monda. Okay, all right, let's go ahead and get started without any further ado. This is the RHC self survey, and when do RHCs get inspected? You have to be inspected in order to get into the RHC program. So somebody has to do it, either the state, Quad A, or the compliance team will go out there and do those inspections. If you're in Alabama or Kentucky, as of right now, those states are not doing initials. So Quad A or the compliance team, that's your only option to get into the RHC program. The state will not come out and do that. The state in Tennessee, where I am, they are doing inspections. In fact, we have inspections going on right now at 2 of our RHCs, and cross our fingers, so far they're going really well. So hopefully I will not get a phone call. Let me turn my phone off here. We'll get a phone call in a session saying, "Oh, we need this," but ask your state if they're doing inspections. So did one of our panelists have something to say about that? Nope.
Nope.
Nope. Okay, I thought I heard somebody in the background, maybe just shuffling papers. But so that's what's going on. So right now, ask your state if the state is doing inspections. A lot of states don't ever do inspections, or they put you on what's called a tier schedule, which means it's going to take them 2 or 3 years, and you're gonna have to hire Quad A or the compliance team. And it's one of those things that both companies provide absolutely excellent service to you guys. So that's just the process that you have to go through in order to become a rural health clinic. Objective that we're talking about is you have to meet 9 conditions of participation whenever your surveyors are looking to you to become a rural health clinic. Those 9 conditions of participation are laid out in the CFR. The CFR is not very detailed. It is not on a granular level. It's really not there. There's probably 7 or 8 pages of information in these regulations. Then they also put out, or in the law, then they put out regulations, and they put out interpretive guidelines as well, and that gets a little bit more detailed. But this is what you're trying to prove to your state inspectors and to Quad A and the compliance team, is that yes, you have met these conditions of participation, and you have a process built that will continue to meet these guidelines as you go. We have prepared together a document called a conversion guide. It's a Google Doc. It's about 17, 18 pages long, and it goes through the process in detail there. You can get that from our website. We will post this video onto our website. It's our COVID-19 website and our certification website called ruralhealthclinic.com. We will also email you the link to the recording of this. It'll be on YouTube. It'll be on our RHC information group. So you will be getting this information. So don't worry if you don't have the slides. I was a little bit behind. Normally I send the slides out ahead of time, but I've been battling a little bit of pink eye. the last couple of days, and I'm sort of behind on my schedule, so I apologize for that. Here's a bunch of documents that we put on our website at ruralhealthclinic.com, certification materials, to help you guys get ready for the self-survey, mock inspection, because we're skipping a bunch of steps to go to the mock inspection survey, self-survey portion of this, but you're going to have to do a lot of things before you're even ready for TCT or for Quad A to come on site. So we're giving you this information here. Again, all these links, when we send you this PDF, all these will be hyperlinks, and they will work. You can actually get into these documents, and they will help you prepare for it. So you can see we have 9 steps for you guys to pass the RHC inspection. We're skipping all the way down to conduct a mock inspection or self-survey and prepare an evidence binder. That's what we're really going to focus on today. So you're going to have a lot of work to get to this point where we are today. And we've got 8 poll questions for you. So before we get started here, Danny, if you'll open up this poll here. And this is a little bit of a subjective thing here. The most important step to pass an RHC inspection is to prepare and maintain a comprehensive evidence binder to present to the inspector. So, Kate, is that a really good idea, or are there other things that are more important?
Oh, there are a lot of important things, but this is a really good idea. It takes a lot of the stress out of the day. And also, one of the things we find, if you as a manager are not there the day of the survey, this makes it a whole lot easier for somebody else to give you a successful result, because they have that binder and everything you need should be in there. So it really is an important piece.
And Diane, do you have any comments on that as well?
And I completely agree with Kate. You know, having that evidence binder at hand and then making sure that it is up to date, and that everything, you know, that you have your policies that are ready and that all of them, you know, are the same. That's the one big thing. And I love what Kate said. How many times do we show up and the person who's led the RHC project has a sick day, you know, because it's a unannounced inspection. So I like that.
Okay, perfect. Okay, and then Danny, do we get any results from our question?
Yes, sir. 89% said yes and 11% said no.
Okay, perfect. Okay, well, it is a little bit subjective question, so there could probably be room for that, but I think that is one of the things that you need to do. And what we've done is we send you a notebook, and basically it has a table of contents in it. Sometimes if we're in a particular state, we know what the state is going to ask for. We've got their little listing of things they ask for, so we make it very specific to that state. Or if we don't know, in general, we'll put together a evidence binder that looks something like this. One of the things I'll put these little arrows in here every once in a while is because some of the things we run into are, especially this one here, inpatient services agreement, proof that you have that. You know, back in the old days, that was very easy to get because it seemed like everybody had a letter from the hospital administrator, and it seemed like everybody could admit to the hospital. And as healthcare has changed over time, now people have hospitalists, and you typically have to go through somebody to admit to a hospital. So Diane, what should an RHC have to prove this particular piece of the requirement?
I think what's really important, I'm sorry, is that whoever is going to be responsible for that admission, that you have, that you can show that, you know, that there is a letter with the hospitalist, that you name who the hospitalist is, or who the hospital's care team, admission team is going to be, or if you can show that they are credentialed, that they have credentials in the hospital. You just have to do your best. You know, trying to get a letter is important if you can, but sometimes you can't. And especially if you can talk it through with the surveyor and, you know, explain what has happened in the past. What is your process? And if there's a policy to back that up, that's even better.
Okay. And Kate, do you get anything on that?
No, I would agree with that. The only thing I would say, the regulation says there is evidence that your patients are being accepted. So you really, if you can show evidence in patient files that your patients are being accepted at the hospital, you don't need a written agreement. And certainly provider-based clinics don't need a written agreement.
Yeah, that should be pretty evident. And then the other little arrow on there is quarterly chart audits. I know this is probably not a part of the mock or the self-survey itself, but just we get a lot of questions about how many quarterly chart audits should the medical director be doing, and how many, and how is that process? So Kate, can you just enlighten us a little bit on what the quarterly chart audit process should be for a rural health clinic?
Well, sure. And the most important thing here is it's going to match your policy. So if you choose to review 10 charts a month, then we're going to look for evidence of that in your minutes. And the point is, you want to do enough so that you can see any patterns. You're doing this for a reason, to see what we're missing, what we should do better at. And so if you're missing an element and you're only doing 2 or 3 charts, you're really not going to come up with it. And of course, that feeds right into your biennial evaluation. So you've got all these charts audited through the 2 years. And then at the end of that, you can put it together into a nice report.
Yeah, and Diane, do you have anything on the quarterly chart audits? Because I know when the interpretive guidelines came out a few years ago, I think it was in January 2018, when you read about the chart audits, it talks about a physician having to review at least 5% of the medical charts in the program evaluation, or I think a minimum of 50 charts. And so again, those are interpretive guidelines. They're not hard.
Exactly.
But
exactly. And it would be important to just recognize if your state has any guidelines, if they're prescriptive, any regulations. But other than that, I agree with Kate completely that whatever you decide as an organization, just make sure that your practice is lining up with what you've decided in your policy.
And then one last question on that is closed charts. People always ask me, what do you mean by closed charts? So Kate, can you give us a little bit of a definition of a closed chart?
Oh, that's a great question, because people ask this all the time. So it's obviously someone who's deceased. I will call that a closed chart. But the definition beyond that, I've heard everything from 1 year to 3 years they haven't been in your practice. The other group is somebody that's requested transfer of records to another provider. Perhaps they moved away. That's an easy closed chart. But beyond that, if they haven't been in a year or two, you decide what your definition is. You can find a lot of definitions on that subject. But and the other thing, make sure when you do your chart audit that you identify closed. Because they'll say, oh, there's closed in there. Well, if you can't show us, then it's not there for your biennial, right? So make sure if you're doing one of every group, whatever you pick, 10 a quarter, if one of those is closed, you won't have any issues for your annual or biennial valuation.
Mm-hmm. Yeah, Diane, is it a good idea to look at maybe all the deaths in your clinic if you've got a patient that passes away, to look at those charts? And is there certain policy? I seem to remember, I don't know if it was TCT or Quad A, where there's a policy that says something, if you have some types of deaths in there, that you either review them or send them out. Maybe I'm just dreaming that, but
you're not really dreaming. It's basically, any accreditation organization is really concerned with safety in their facilities. I know, and certainly in the ASC program, they have to report death in clinics. And I believe also for RHC programs, that's a very important thing, because it's alerting the AO that there may be a problem for a death in the RHC, not a patient that just is deceased. But if there is a death in the RHC, that's probably a good idea.
Okay.
It's an important distinction, not one of your patients dying. Good point, Diane.
Yes. Okay. Perfect. I was worried about that, because I was like, wait a minute, if we have a patient die, we're going to be reporting all the time. So okay,
a lot of times. Yeah.
Good. Okay, perfect. That's where I was confused. That helped me already. So very good. Thank you. Okay, and then here's the links to the evidence binder instructions. We provided about 6 or 7 pages of instructions, and the table of contents for you. So you basically go out and buy you some Avery folders, put those in there, and you should be good to go. That'll give you a head start for it. And there's a lot of forms. This is a TCT form for keeping up with your licensed staff members. Remember, you want to make sure you get everybody credentialed, have a nice file for them, and so that the state so that TCT, the state, and Quad A can survey that and make sure that all these licenses are up to date. Make sure you have copies of those in your evidence binder. It's going to be very important that you have that to show the state or show everybody. Poll question number 2, Deanie, if you'll open this up, when your RHC inspectors arrives, you should A, send them away if you're not entirely ready. B, try to keep them in the waiting room as long as possible with as many COVID patients as possible. Or C, find them a nice private place to work away from all your sick patients. So Kate, you wanna tell me about what the process is whenever you guys show up at a clinic? What do y'all normally do?
Well, the survey starts when we pull up in our cars to the front door, obviously. And then, we're looking for the hours posted. We're looking for safety getting in the building, handicapped patients getting in the building. And then, of course, we walk up to the desk and tell them we're here. And then they sit us down while they all go in the back and breathe for a little bit. And then we, of course, are invited in to start the survey. But we're watching and we're evaluating that waiting room, as you'll see in a moment.
Okay, perfect. Diane, you got anything on the process when you get there?
Well, I think just like Kate was saying, our eyes are already open, and so we're there. We're ready to see how you live your day-to-day RHC activity. So if you're keeping us in the waiting room longer than 15 to 20 minutes, it just kind of makes us, raise our eyebrows a little bit. And certainly, I will say one thing we have every once in a while is that we'll show up, and then the person who is in charge of the RHC readiness activities, they haven't come onto site, and sometimes the front desk will say, well, we'll bring you into the back when they arrive. That's really taking a large chunk out of our day. So just like Kate said, just let us get into a spot, hand us the RHC evidence binder and the policies, and we'll engage with the person as soon as they arrive. Would you agree, Kate?
I would agree 100%.
Absolutely. I think anybody nowadays, especially now with COVID, but even before that, nobody wants to sit in that waiting room very long with, you got a bunch of snotty-nosed kids that are coughing everywhere. It's really not the place you want to be. So make sure your receptionist knows that, oh, yes, we have very important people from TCT and Quad A coming to do this inspection. Let them know where the evidence binder will be. Have a process. Or if the person who's in charge of the RHC accreditation is not there, that whoever's there will know how to get this thing started. That's why that question is out there. Danny, what did our results say from the poll?
Yeah, 98% that said find them a safe place to work, and then 2% said keep them waiting in the lobby while you panic.
Those are the 2% that are going to have a hard time passing. But okay.
Well, I'm glad they still have a sense of humor out that. I like that.
Okay, our third poll question here. What COVID-19 precautions should RHCs be taking? Number A, should you activate your pandemic emergency plan? B, evaluate your PPP supply chain. C, evaluate your infection control protocols. Or D, all of the above. And Diane, on this one, what is Quad A telling the RHCs?
It's definitely all of the above. We need you to, you will have a unique opportunity now to see if your pandemic emergency plan is working. You have definitely had an activation, so that's going to count as your exercise, as an exercise. And, as you are living through this, we want you to be making notes, updating it, because you do have to have that after action plan report. But guess what? We don't know when this is going to end. So you're living, your plan right now. And then go through the clinic in every portion of the clinic in, how you're doing spacing in the waiting room, your disinfection plans for high-touch areas, your source controls and engineering controls. We need to be looking at everything right now.
Okay. Kate, do you have any comments on that one?
Absolutely. And the one thing I would add is let's put a sign on the door. And if we have patients that are these symptoms listed out, go back to the car and call us. unless we have a different setup right now. Some of the clinics have separated out, and they have sick clinics and well clinics, if you will. That's very important, but a way to keep infected patients, of course, away from other patients. And then taking temperatures of the staff every morning. Everybody gets their temperature taken. Let's make sure, because there are so many people with this are asymptomatic, and it's really important. And the last thing is train. Infection prevention, let's look at it again. The other big thing is taking off your PPE. There's many people that don't know how to do that properly because we haven't experienced this kind of a thing. And that's really important training. There's great webinars on CDC, YouTube. You can find proper instruction on that.
Okay. Thank you, Kate. I was taking copious notes there. Danny, how did our attendees respond on this one?
Yep, you got D, all of the above.
Oh,
100%. Excellent. Good group. We got a good group. Good.
Thank you. Okay, very good. Okay, now just talking about COVID-19. Here's, I don't know what, this was Taylor's slide. I put this on here because Taylor Catano in Louisiana, Southern Avowals is the company there. They have something called a booster, COVID-19 booster. It's got policies and procedures, and it's got an emergency plan in there. It's got everything related to COVID-19. It's $29.95. What I do is we start up a new RHC is I buy a copy of it and stick it in there because I'm a CPA and Taylor is an infection control specialist who knows everything there is about COVID-19 and infection control. So we use his documents. We pay him every time we use them. So we would recommend, if you guys, I would definitely, that's the best $30 you'll spend to help protect your patients, and go through those documents. There's posters, there's all sorts of stuff in there that's really, really neat. So we highly recommend that. And then we did a webinar with Taylor and Patty Harper, who most of you guys know from Inquisic, and she's fantastic. And so they gave us a lot of documents and a lot of information about infection control, hand washing, and all that. We did that a couple months ago. March the 12th is when we did it. So those are the documents for COVID-19 as well. And then we added some more. Again, we have our website is ruralhealthclinic.com COVID-19. Used to almost every single day I would update this website. Now it's sort of slowing down a little bit, so it's usually about once every 3 or 4 days we will update the website with new information. So let's get started doing the mock inspection. First thing you want to do is conduct your own mock inspection. And this is a form from the National Association of Rural Health Clinics. This is when I took the test for becoming a certified rural health clinic professional, and I would highly recommend that you guys do that. If you click in the bottom here, this hyperlink to the NARHC Academy, there is a way for you guys to participate, to study for the test, and this was one of the documents there, and it's on their website, so it's not official part of the thing. So we can use this today, but do your own and Diane, how often should a rural health clinic conduct their own sort of mock inspection? I hear things like monthly, I hear quarterly. I think that was in one of the tests. Probably one of the test questions I missed on the test was how often should an RHC conduct their own mock inspection? So from your standpoint, how often should it be?
So the regulations basically kind of urge you to, in your annual program evaluation, to look at your compliance with policies. So that would be the bare minimum we would suggest. Just like Kate had talked about earlier, if you're going to be doing chart audits, you need to be doing them regularly enough for them to be meaningful. And I think that a good administrator is really going to be walking and rounding in their clinic pretty regularly. So at least quarterly, monthly is ideal. Because you need to understand when there's a breach in how your process is going, what's the cause of that breach? Is it education that needs to take place? Does the policy need to be updated? Do we need additional supplies to be in compliance? So the more frequently that you're doing this, and it doesn't have to take a long time, wouldn't you agree? I mean, that could be a walkthrough that could be, 20, 30 minutes. It's a little bit more, high level, not in the weeds. But more often is better.
Okay. Kate, do you have any comments on that?
I would just add one other thing, and that's quarterly would be ideal. I think monthly would be wonderful, but we're so busy, it's not likely. And that is to have someone else do it in the staff, because if you do it as the manager, you are so used to looking at things. You may just, how you walk right by some things because you just expect it to be different. And so have somebody else and get them involved, and that buy-in will make for greater compliance.
Mm-hmm. Yeah. One thing too, I recommend to people is, and it's probably not the best business practice from an RAC consulting firm, is whenever, a lot of times they hire consultants to do program evaluations, and I tell them, switch up your program. Even if you're using us, get somebody, hire Jim Estes, hire Patty Harper every 2 years to do your program evaluation, because different consultants have different eyes and they see different things, and that will help you as well. So think about that as well. Okay. All right, let's move on, because so now we're starting taking our facility tour. When Kate and Diane walk in, they're gonna look in the bathrooms, they're gonna look into the waiting area, and they're gonna look at some patient rooms. So we'll go into more detail as we go through here. Also, they're gonna be looking for the posters. Make sure that your posters are up to date. You can order those online, and they'll cost a few dollars to get those. But make sure your federal and state posters are visible. Sometimes if you have an employee break room, you want to put those in there as well. So Kate, do you have anything on these posters, or is there anything special about that?
Well, it should be 2020 posters. We often find they forgot to renew, buy the new one. And then the other thing is, this is required for every rural health clinic, even if your clinic is in the basement of the hospital. You are an entity of your own with your own billing number, and you should have this poster in your clinic, not in the hospital. And that's one of the things we see. Otherwise, people forget when they move, they have to have this up. But for the most part, this is not a citation. Yeah. We don't see this very often.
And then Diane, you have anything on this?
The only thing I would add is that, yes, you can buy the posters, but all of that information should be available free online, in a PDF that you could just print out if you had a bulletin board. Sometimes money is just really tight, and there is a way to meet that compliance without buying the poster. It just takes a little more effort. I love it when it's a poster because, you just you put it for an auto renewal and they send it to you every year.
Yeah. I think that's what we found is most people have done that, is just auto renew, because a lot of times it's hard to print these things off and they don't look right, and you just get the nice sort of laminated poster and stick it up and be done with it. So that's a good idea. And I had something on my mind to say about that, and I completely forgot. So we'll just move on here. Here is your front door. I think Kate mentioned about the important notice about calling. You can see where this particular clinic has done that. They've told people, and a lot of times I say Patty Harper has in her kit, she has a little thing that says stop. In fact, it was on 60 Minutes the other day when they did the session on rural health. I saw her sign on the door of one of the RHC that she was at, and the 60 Minutes was at in Texas. So have this up here. Have your hours of operation. Chapter 13 of the RHC manual requires that you put your hours of operation up here. So they've got that. Handicap accessible. You need to make sure that your clinic is handicap accessible. And look at the parking lot. Diane, as far as handicap accessible, I know a lot of times we go in there and we see a parking space for handicap accessibility. Do you guys look at that closely and look in the bathrooms? I mean, do y'all, what standards you guys use to look at those, and just give us a little background on that, because sometimes I get a little fuzzy on that one as well.
Yeah, I think that, the RHC regulations just basically say that the facility is maintained to provide service, and accessibility to its clients. That's really important, that it's maintained appropriately. So it kind of ties into there. We all, all of our facilities have to maintain compliance with federal and state and local guidance and regulations. So, or not guidance, excuse me, regulations. So that falls under that. So yeah, it could be a teaching moment if it's something that's small, or if it truly is where a person with different capabilities could not access the clinic, then it might be a deficiency that we would have to address straight on.
And Kate, do you have anything on that as well?
I agree with that. The other thing, we check the back door. You want to make sure that handicapped person can get out the back door in an emergency, and that's something that's often overlooked. So we will go out the back door and look.
Oh, okay. That's great information. I did not know to check that. So let me write on my list here. Check the back door. I've never been doing that, so I'll double check that as well. I know a long time ago, it used to be North Carolina Handicap Code was the one that most states in the South was using, and I knew how many inches the door had to open and the door had to open out, and 60 inches was in front, and all the bathroom rules and all. But I don't think, and then of course the Americans with Disability Act came out, and and there's those regulations as well. So look at those regulations, especially if you're building a new space, because it's a whole lot easier to do that ahead of time than it is to sort of redo what you've done because you didn't meet those disability.
Well, a lot of this is state-specific, Mark. Very state-specific regulations. They are exempt from life safety code, but you must address your patient population.
Perfect. Yeah, that's what it's. There's not a whole lot of sort of granular detail in that. And then one thing, I remember what was slipping my mind was there are two types of deficiencies that you typically run into in a rural health clinic. There's a standard level of deficiency that basically says, yeah, you made a B or a B plus, but you didn't make an A, and here's what you can do. You need to fix this in order to better serve your patient and protect their safety and your employees' safety. So that's a standard level of deficiency. But if you have a condition level deficiency, that means that you so far missed the mark that Kate or Diane will need to come back and double check this and make sure that you're meeting that, because you've not met those 9 conditions of participation. So you want to, obviously, you don't want to have condition level deficiencies, because that's usually bad. Diane, do you got any comments about that?
Well, there's actually a third level, which I've unfortunately experienced. Yeah, but you're right. I mean, the most common are going to be your standard deficiencies, things that you have, you're either in compliance or you're not in compliance. And then with standard level deficiencies, we're saying that you have a certain amount of time that you need to correct this. And as long as you can provide proof of correction and that you've retrained your staff, changed any policies that you may need to change, and then corrected, and you can show to the accreditation organization that it has been corrected, then that's okay. A condition level, like you said, would mandate that they have a certain amount of time to correct, but that the accreditation organization needs to send another surveyor to put eyes on the clinic to ensure that, that patients are getting safe care in that clinic. It usually has to do with egregious, non-compliance.
Okay. And Kate, you got a comment on that as well?
No, I would agree. It's really all about the severity of the problem. Most of the condition level deficiencies are patient-related, safety-related, infection prevention-related. I mean, if you did nothing for emergency preparedness or didn't have an biennial evaluation, that's condition level. You can do pieces and parts of it, but if you didn't do anything with it at all, and that really isn't related to patient safety. So it really depends. It adds up to the number of elements within a CFR that makes it condition.
Okay, perfect. Okay, and one thing that we have been written up a lot for is not disclosing ownership, the medical direction, and the principal direction or management of the clinic. So we put together a little certificate there that you guys can put in your lobby that will put the ownership. You will name the ownership, the medical direction, and the office manager of the clinic. And you can actually download that, fill in your information, put that in a little frame, put that in your lobby, and that should suffice for meeting that regulation. So let's see. Okay, so now we're looking in the room, and Kate, when you're in the waiting room and you see a bunch of toys and a bunch of children's books in light of COVID-19, is that still a good idea?
No, actually, in light of COVID-19, I would have no toys in that waiting room. I would have half the number of chairs in that waiting room, no bag, at minimal. We're gonna disinfect that room every night now. So we don't want to have those things in the room. If it were non-COVID time, I would be asking to see the policy on how they're cleaning those toys when I got in the back. And if they were stuffed animals, they're got to go. None of those can be cleaned. So I like the lamps because it can't be knocked over for a child to be playing with it. It's good that it's stationary on the wall. I'm looking for covers of outlet covers. It looks like it's, I can't really tell on that if that's a carpet there. It looks like a carpet, doesn't it? Don't see that too often because that's tough to keep clean. Yeah, it's tough to keep clean. But if it was clean, I mean, and they're going to have a process for keeping it that way, I'd be all right with that.
Yeah, and then what about the? It looks sort of like fabric on the chairs there. Is that an issue, infection control issue, or?
Well, you know, they can be sprayed, they can be cleaned, they can be, I can't think of the name of the product, you spray them with so nothing stains it kind of thing. It depends on the type of patient you're serving. With a lot of children, if it's a pediatric office, I probably wouldn't be real happy with that. It's going to be tough to keep it clean.
Okay, all right. Diane, you got anything on this one?
So the only thing that I would say, and I think Miss Elsie and I were talking about this yesterday, is that, you know, we're in a COVID-19 pandemic, but those same infection control practices should really be considered during the season or just any time in the year. We really need to look at how we best serve our patients all the time, and especially with pediatrics. I mean, I think that was something that Elsie and I talked about yesterday. It's really, you've got to see, you know, any environment through the eyes of a child and what safety elements could be there that we need to, like Kate had said, with electrical outlets, you know, but really, even beyond the pandemic, let's think about viewing it at a child's level and that what we need to be doing all year long.
Okay, perfect. Okay, let's move on. We got a lot of these here. Here is another picture of a lobby, and looks like they've removed their, probably some flyers or something like that in here, some business cards, maybe magazines are now gone. Providers' licenses are up here. Is there, Diane, can you just give me some comments about those sort of issues there, about whether they should be putting up providers' licenses, magazines, books, all that sort of stuff?
So as far as the licensure, you know, they have to be we have to have them available in the office for the surveyor to see. You know, business licenses, things, they usually are displayed in the business office. You know, a lot of people do put, you know, some type of provider information on the walls in the waiting room. We see that quite frequently, and that's okay, but I would just be aware. I've walked in and seen DEA certificates posted, and I'm not sure that that's a great plan.
Yeah.
And I would just say in those waiting rooms, any high touch items really, at this point, I think should be kind of eliminated if possible. And just like Kate was saying earlier, we need to get strategic about removing furniture so that we maintain that social distancing. If we need to put engineering things in place, like it looks like they have a sneeze guard at that registration area. And I know Kate and I for years would walk into places and you would see these now open types of check-in spaces, and we thought, wow, that's just not a great idea. And now people are having to retrofit that plexiglass again. So, you know, and also if you have water coolers, we see a lot of places that have water coolers. Those need to be taped off, not in use. If you have a bathroom in the lobby, in the waiting area, we've got to figure out how are those being disinfected. If you have the, you know, the dryers with the forced air, is that a good idea now? You know, you just really need to rethink and look at the guidance and see if what you're having is either putting people at more risk or it's in line with the guidance right now.
Okay, perfect. Kate, do you have anything on this particular issues?
No, that's I would say I wouldn't post the licenses either. I would not recommend that in the waiting room.
Okay, perfect. Yeah, I don't know where I saw that. Somewhere I saw something about provider's license. Like, I don't know about that. So especially, like you said, when Diane said talking about the DEA, I'm like, yeah, that is really a really bad idea. So perfect. Okay.
Really bad.
Very good. Very good. And there's another one. I didn't really see anything in this one. I think
There's that water fountain.
Oh, the water
That water
fountain.
fountain.
There's the water
Yeah.
fountain. Yes, I missed the water fountain. Absolutely. That's
Take
so
that
we need
up.
to put, yeah, we need to shut that down. Shut down the water fountain. That's good. I completely missed it. Okay. Let's see here. Okay, next one. Here's another one. What I noticed was the door was wide open. So you want to make sure that you keep that door locked. You want to keep security for your people because, I mean, we live in a time where there are crazy, crazy people that do crazy things. So you want to keep security. A lot of people have like a buzzer on the door to where you let people in and let them out. So you want to control people that go in and go out, and your back doors need to be locked as well. Kate, is that sort of your thinking on this picture?
Absolutely. That's not a secure waiting room, and you're sitting there. Anybody could wander back. The gals are going to come out and call a patient back. They'll open the door and bring you back. And to the back door being locked, that's a really important piece. The clinic people tend to run in and out of the back door. It is not a safe situation. That needs to be locked and easily accessed from the inside, either a push bar or a deadbolt that you could turn. No finding a key to get out the back door.
All right, Diane, do you have anything to add?
No, I agree with Kate on that. That's completely, yeah.
And yeah, that's and some of these there's not going to be a whole lot to talk about other than what's been said. But on this one, what of course I saw was the plexiglass, and absolutely you can say this one looks like it's sort of been retrofitted as well. I don't think that plexiglass was there before COVID-19 the way it looks, and because it sort of doesn't sort of match the other stuff. So if you have and I've got some clinics I know of that we've argued about this, they did not want to put up plexiglass before COVID-19. Now they really need to be doing that. So that's, I think that's been added. I see something on here that's right, I don't know what this is, some type of disinfectant there, but that's probably something that we need to figure out what we can provide so people can wash their hands with using disinfectants or whatever. Y'all see, Kate, do you see anything on here besides what I was mentioning?
Yeah, I'm not happy with that. I'm not happy with that candy dispenser. If I remember back to when I got candy out of one of those, you have to cup your hand under that to grab it because it'll go over the floor. And so it's fraught with issues, particularly now, but even in general, I don't think I want that there at any time. And I love that, you know what, those COVID screens, we could call them, are really good for PHI. We find people sitting at the desk calling to patients on medical results, and you can hear that in the waiting room. And that's really something you got to be aware of with HIPAA. The fire extinguishers seems to be high enough that the kid couldn't bother that. We don't really see them very often in the waiting room, but I could probably live with that because the child couldn't reach it. Not real happy about an open trash can in the waiting room with people sneezing and coughing in tissues and somebody getting into that, a youngster. So, but otherwise we're good. Maybe half the chairs. We're going to play the chair game. What's that one called? Oh gosh, just came to mind with that.
What? Yeah, I forgot.
What?
Musical chairs?
I was thinking, I can't.
Musical chairs. Start taking them away. I mean, we're not going to have patients sitting in that full waiting room. That's just not going to happen for, I don't know how long, but for a while.
Yeah, and Mark, I just realized going back to and I don't want you to go back to it, but when we were looking at the entrance to the clinic, and then I'm seeing it here as well, and I know that a lot of these pictures are pre-COVID, but we need to have, it's a recommended practice that in healthcare facilities that everyone is masked. I mean, we're just, if you don't want to do it out and about, that's your choice. But in healthcare facilities, the recommended practice is that we're all wearing a face covering. So I would just ask the clinic, are you providing and having some of those really inexpensive cough and cover masks, that are available in case someone walks in without a face covering? You obviously have to have a higher level of masking and PPE for providers that are, taking care of a suspected patient. But do you have kind of a little infection control station? I think what is on that countertop is actually alcohol-based hand hygiene, but it's not, it should be, usually it's flipped over and you just do like this. So now they've got it to where someone's having to pick it up and do this. So let's just rethink this. Where are we going to have those entry points that we want to make sure patients can be in guidelines to keep themselves, safe in the waiting room, but also to keep our staff safe? That's really important. We're frontline workers. We don't have a choice. We have to show up. So what can we do to make sure that we're, reducing the risk in the clinic for our staff.
Okay. That is perfect. That's exactly why we're having this session today. So thank you for that. And this is another picture of the same thing, just little. So I think your comments would apply to that. We'll probably have to move along here. This is the checkout area. And Kate, do you have anything particular about this checkout area? I didn't really notice anything except for the battery backup there, which was out.
Why are the battery backup sitting there is what I wondered, but I really didn't see anything in this picture now.
Yeah, okay. Diane, do you have anything?
So the only thing I would say is that since you don't have plexiglass there, you don't have a sneeze guard, we still have to maintain our social distancing. So if you can't do that, a simple thing would be to take some colored painter's tape or something, kind of measure out that 6-foot spacing so that people aren't leaning over. And I think that's why they put those boxes there, that people aren't leaning over, to get there. But how can we, again, protect not only our patients, but our staff by giving those kind of cues to stay back a little bit. And just even going back to the chairs, like Kate was saying, remove some of the chairs or take that painter's tape and put it over the chairs so that visually there's a cue, don't sit here or stand back.
Perfect. Okay, perfect. Very good.
Hey, Mark, we got a
Yes.
couple questions about the lobby.
Okay, let's go ahead, Danny, and tell us what you got.
Yep, one of them says, due to the community's paranoia, we have closed our lobby. Do we still need to remove all magazines and limit seating with it being closed? That's the first part of her question.
Say that again, Danny.
Yep, so if their lobby is closed, do they still need to remove all magazines and limit seating? So if their patients are waiting in their car and then they come in.
So they have nobody in the lobby? I mean, I guess that makes sense, but it just seems to be better right now to empty it out.
Okay, and then her second.
But no, there wouldn't be a requirement, I wouldn't say, but.
Okay, and then the second part of her question or statement, it says, with such a small office, we have the mornings for sick patients and afternoons for non-sick, and we clean down the break in addition to between clients. We plan to do this procedure until the pandemic is declared ended. Is that okay?
That is a great process, and let's block the patients into sick and well, infected or possibly infected in different times of the day, and sanitizing in between. Now, by the 1135 waiver, you are permitted, if you can find another room or another space in the building, not even part of the Rural Health Clinic, you can see those patients or whichever group you choose in that section, and that is permitted and encouraged, actually, to separate them totally. If you have the luxury of finding another space, that's the issue.
Yeah.
And then going to the other one is, should water fountains be removed or can a sign be placed on it just not to use it?
I would put yellow grease tape on.
Yeah, it really is. It's something you have to give real visual cues that it is not to be utilized. If you can easily just take the water and shut it off of that, that's great. You certainly don't have to take it down. But, and it's really interesting. It's just really thinking about all of these things and, just be thoughtful about it and try to come up with a policy that falls in line with guidance. I love, Kate, what you were talking about that secondary site. Pediatric offices have been doing this for years. You have a sick waiting room and a well waiting room, and we love it. The problem that we have is that we have asymptomatic positive people. So if you're doing that, you probably may have people in your second part of the day that are not symptomatic, but are positive. So we have to really just step up our game, even for people that aren't obviously unwell.
Which is why we're all masked all the time to take care of these patients. And I just thought about the valve. On every water fountain, there's a valve like a piece of plumbing. Just turn the water valve off, and then there'd be no water coming out of there.
Mm-hmm.
Okay, what about water coolers that have large jugs and you use plastic cups with them?
Any high-touch
area.
Yeah. See, well, I would just say you have to be able to. I just was reading something last night about airports, and Kate and I travel in airports a lot, so how we go back into an airport is going to look very different. And one of the things that they were talking about is that any high-touch area, you really have to consider how you're going to be doing that. Well, we're in a healthcare facility, so we have to look at the guidance, and that guidance is saying high-touch areas, you have to disinfect them more. You have to look at their ability to be something that's going to transmit the infection, with that high-touch. So just look at it that way. I don't have the ability to have my disinfecting wipe and go through and touch those cups. And I know sometimes the cups come up and they stick and people touch 2 cups. I'm really OCD, so that would bother me anyway. I don't know.
Okay.
That's all.
Danny, you got any more?
No, that's it for now.
Okay, perfect. All right, perfect. Thank you. Okay, let's and in front office, what sort of things? I know I typically don't go a whole lot in the front office when I'm doing a self survey or mock inspection, but I would think HIPAA would be a big concern, having sort of guards where people cannot see the medical information for people. But is there anything in particular you guys look at, Kate, from y'all standpoint?
Well, like I said, when we're sitting in the waiting room, we're listening to that gal at the front desk call patients, and we want to make sure we cannot hear that PHI. Secondly, we walk up to that window, we will see files that are waiting to be, like usually lab reports, results of tests that are waiting to be scanned in because that person gets that job. It's a simple process here. Put something over them or turn them over. It's that simple. And we want to make sure those screens are all inside facing, so there shouldn't be any problem here with PHI as I see it. And we've got a window there as well to close for calls. So I think we're good on this one.
Okay. And then Dan, do you have anything as well?
Elsie, would you mind saying what you said yesterday about the what's in the waste paper basket below? I thought that was kind of an interesting comment that you had.
Well, it's often you will see underneath the desk paper that's been thrown into the receptacle. And when I've asked before, now how are you? What do you have in there? Is there anything that would be privileged information, protected health information? And most of the time, they will say no. It's just a blank piece of paper, something that we have nothing that would be protected health information. I have pulled out on many occasions lab results, often many kinds of information. It definitely is protected health information. So I'm sure their intentions were to put that in the shredder when the shift was over. But you've got to be careful about that you make sure that if you're discarding something in the unprotected waste can, that's just clear for anybody to see that it does not have protected health information. So that's something they don't often think about protecting.
Yeah.
Good one, Elsie.
Yeah, Elsie, that's really good information. I know when we prepare cost reports here, we end up with a little PHI. So I have a box off to the side where I basically just put all the information that I'm not going to, that if I've scanned it or I'm not going to use it anymore, you put in that box, and then about every month or so, we take it over to get it shredded. So they probably need to have some type of special box or something where they put that information. So it's very easy to throw it in the trash can and not really think about, oh, there's an MBI number of a patient on there, or there's who got the flu shot. We have flu shot logs and stuff like that. So very, very important. Thank you, Elsie. That's very good. So let's move on. We're gonna run out of time if we don't speed up. So let's go ahead and yeah, y'all know me too well. I always take too long on these things. But Danny, we open up the question here. When the survey asks a question you do not know the answer to, A, pretend like you don't hear them. B, just make something up. C, say, let me refer to the policy and procedure manual and I'll get right back to you. Or say, I don't know and I don't care. And we had somebody say that one time. We got 70 pages of deficiencies. But Diane, you wanna cover that one?
I just think we're all human beings. I've been on, the receiving end of questions that in a hospital I was a little bit unsure of. And I think that the best thing you can say is, if you don't know the answer to something, my process is to ask someone to look at the policy and procedure manual to back it up. And that's perfectly acceptable if it's in the minutia. But what we are wanting to make sure that everyone that's working in a rural health facility is aware of the common practices and protocols. So again, big picture, we want them to know if it's a detail or something that they don't do regularly, then it is acceptable to, to look at a valuable resource of a person or of a policy and procedure manual.
And Kate, do you have anything on that one?
Yeah, I would always say it's really important that not everybody can know everything, but they need to know where to go to get the answer, whether it be the manager or the policy procedure manual. So they should know, and let's go look it up kind of thing. Absolutely.
Okay. And then
did somebody really say I don't know and don't care to you?
That's what they said to the Alabama inspector. That's what she said. She questioned, the inspector quoted exactly what the people said on certain things, and like I said, we ended up with 70 pages of deficiencies. So it didn't go well. Danny, what did our people say?
96% said, let me ask, and refer to the policy and procedure manual, and 4% said to pretend you don't hear them.
Okay. Those are the people that we're going to have problems with. Okay. All right. Let's go on. A couple of things that when we go through the tour of the facility, we're going to look for lighted exit signs. They're very inexpensive now. You can go to Lowe's or Home Depot, get those for $50, $60. You want to be light. I know I've heard Kate talk several times about the lighted ones. I mean, especially if you have a fire, electricity's out, they have batteries. That's a way to show people out. Your fire extinguisher, once a year, you should have an outside company that will come and do whatever they do. I have no idea what they do, but they will check it. And then once a month, what the state fire inspectors always told me to do was you need to have somebody that takes that fire extinguisher, turns it upside down, shakes it, turns it back, and then as long as that little yellow arrow is in the green, then it's charged and ready to put out a fire whenever you have one. And then of course put floor plans out so people can see how to get out, especially if you're in a hospital building there where there's a lot of exits and a lot of ways to go out. In most of the RACs I work with, you can probably see the outside from where you are in most of them. So Kate, do you have anything on this? This is actually your slide, so you know this stuff very well. So go ahead.
Well, most important is in a dark, smoky building, you've got to show me how to get out of there. And so we only need the floor plan posted to show me when it's on an interior hallway. If I can see that lighted exit sign from the room I'm coming out of, we're good. But if I can't, we're in an interior hallway, then you got to put that arrow up and show me which way to turn. That's really important. Most of the fire safety regs are state specific. A lot of states have real specific, clear regulations for fire safety. And of course, you have your annual fire drill.
Perfect. Okay, Diane, do you have anything?
Last thing, my number one question that I always ask facilities is, so you've got a fire, you've evacuated, where's the spot where you all gather to make sure that everyone's out? And so I want to make sure, I'll ask that a couple of times to people to make sure everyone knows, because I think that's rather important,
Yeah, you should be, we tell people is practice your evacuation drill, because the evacuation drill, your evacuation plan should be the same for most emergencies that you have. And so if you practice that, you should be good on something like this. So okay, perfect. All right, let's move on. And then here's walking down the halls. What we've done is we have basically a mock inspection, a little cheat sheet that goes through and it takes the SOP, the state operations manual plan, state operations manual, I think SOM, and it has what's called J codes. You'll get a lot of J codes if TCT, they have a way to enumerate what their deficiencies are. Quad A has a numerator for that as well. So we've basically taken the state's numerators, the J codes, and gone through those and made a checklist of it. It's about 20 pages long, and we will go through that. So here's our hallway. From what I can see, I don't really see a whole lot of issues there. And typically, again, you really shouldn't have any barriers in there. It should be wide enough to get a handicapped person through there. Overhead ceiling lights should be free of bugs and debris. Basically, you're just going to take a look make sure it's safe for people to enter and exit the building and the hallways, and make sure that I've seen people with copy machines, with charts sitting out there, with little things that turn down and the physicians can write on, and they're in the middle of the hallway. I've seen places where they triage patients where they're doing the wait. They're saying, "Oh, Mark is fat again," and they're calling out stuff. So usually you don't have triage stations in the middle of your hallway, so due to PHI. I'm forgetting whose turn it is. Kate, you want to? What are you looking for on this, and then we'll go to Diane.
I don't really see any problems in this hallway. It's up to get into the detail. I love seeing all the alcohol-based hand rubs. That's really very much encouraged. Actually, a little aside, last September, CMS started a meeting, I think it was monthly to start, on this very subject. And they have a white paper that proves that your hands are better disinfected with that alcohol than soap and water. And of course, unless they're visibly soiled, you got to get rid of the visibly soiled first. But the alcohol-based are better, and they're encouraging great use in that. And it couldn't come at a better time right now. But I don't see any problem here. I see lighted exit. I can't tell what doors lock and what don't lock. But if there's doors down there with medications or supplies behind them, they should be locked, certainly. Nice, clean hallway. I'm good.
Okay. Diane, you anything?
I'm good. That's good.
Okay. Good. All right. Let's move on. Okay. Here's our next question. Will the RHC inspector observe a patient visit? Answer A is yes. Under recent interpretive guidelines, the inspector should do this. Or B, no, HIPAA privacy regulations will not allow this. And Diane, I'll let you sort of comment through this while people start answering it.
Okay, so when the interpretive guidelines were revised in January of 2018, there was language in there that says that inspectors should review, observe a patient encounter. And I think that is it's something, that's a little bit harder in the RHC world because it's such an intimate setting. You're going in with a patient and their provider to, and we're kind of looking for different things. We're looking for that appropriate hand hygiene. We're looking for, the patient's needs to be addressed in a way that they, that is meaningful, that they have enough time to have questions answered. But the thing is, and I think Kate would agree with this, is we as an inspector or surveyor have to have permission by the patient. We cannot, so you would need to make sure that the patient gives consent for someone to observe their care in the clinic.
Okay. Kate, do you have anything on that?
Yeah, we do interview patients on site every time, but we do not go in during the actual physical exam. We review patient care by way of reading the files, interviewing the staff.
Okay. And Danny, what were our responses on that one?
66% said yes, it's allowed, and 34% said no.
Yeah, we have a hard time with it. A lot of our providers don't like when we tell them that the inspector may go in the room with you to see a patient. They really don't like that.
Exactly.
Well, you could actually just observe a lab draw or something else, because it's really, you're looking at, you could look at a portion of the patient visit, but we're just trying to, it doesn't have to be that you go in the room, but a lot of times we see their labs being drawn or something like that.
Okay. All right, next item here is the patient sink. This looks like it's got the little green OSHA, the water, OSHA, what do you call it? Not spill.
Eye irrigation.
Yeah, there
irrigation
you go.
for eyes.
And Diane, how long do they have to I know the OSHA rules state that they should be testing this, and I think it's 15 minutes every week, where they're trying to clear the line from anything yuckies that's in there.
Yeah.
I remember correctly, it's 15 minutes. Is that right, or am I just dreaming that?
I'll be honest with you, I'm not sure about the whole duration or how long it needs to be. I do think that you should be purging those lines. We need to make sure that the temperature is moderated. You can't have hot water going into someone's eyes. But, with all things, just making sure that if you can provide evidence, if an inspector asks about your process, how are you going to show us evidence that it's being done?
Yeah. Kate, do you have an I've heard different minutes. I've heard 5 minutes. I've heard 10. I've heard 15 minutes. You hear everything about what the OSHA requirement is. I think I've looked it up before. If I remember correctly, I thought it was 15 minutes. But Kate, do you have anything on that?
I really don't know the answer to that, but I will tell you it's odd to see an eye wash station in the patient exam room. This should be where the staff is cleaning instruments, where we might need something we have those disinfectants, and I don't know why that's in a patient room. And I'm really not happy with dial soap. I hope the providers aren't using that to wash their hands. I don't know what's in that container on the left. I can't get close to that. We're happy with the disposable eye wash stations that you buy at your drugstore, because they really rarely need them, and this is an expensive process for clinics and not required in the regulation.
Okay, perfect. That's perfect. Okay, let's move on here. Hand washing, obviously with COVID-19, even before COVID-19, we were getting written up for not hand washing. I think the major finding that started happening once people started observing physicians and nurse practitioners and PAs in the room with patients was improper hand washing. We had several deficiencies. I've probably watched this hand washing video 15 or 20 times in the last year. We typically, when you get deficiencies, what we will do when we work with you is we'll have an in-service for your everybody in the clinic, and we'll watch the hand washing video, or we'll go over the process that was deficient whenever the inspector came, and then we'll have everybody sign off on it. So here's the hand washing video that we watch. And do you have any Kate, do you have any comments on just the hand washing process for everybody?
Well, the most important thing is that you really time yourself once and see how long it takes you to sing happy birthday, because it's quicker than you think. You might have to sing it twice to make 20 seconds. It's just like brushing your teeth. You never brush them long enough, and you probably don't wash your hands long enough unless you've timed it and you know the song you're going to sing, and that's really a good way to do it. Sing it through, time it, make sure you've got your 20 seconds, and cover all surfaces of the hands, not just what you see people do. Really very important. Mm-hmm. Always, not just COVID times.
And Diane, do you have anything?
Just going back to what Kate said earlier, I mean, the evidence is out there that the alcohol-based hygiene, hand hygiene is actually, people are more compliant in using it, and it really does a better job. Hand washing in our healthcare setting is when our hands are visibly soiled. So let's, use that hand hygiene, the alcohol-based if possible.
Okay, perfect. All right, let's move on here. This is the patient exam room. So from what I saw was they got one of these old gooseneck lamps here. I can't really tell if the light bulb there is shatterproof or not. A lot of times they have a sort of really heavy plastic seal that will keep them, that will make them shatterproof. So if they were to burst while you're looking at somebody's eyes or something like that, you're safe there. So you'll make sure of that. Also, this particular exam room table looks very good, but some of them I've seen, the sides are sort of frayed. They got holes in them. You can see the cushioning in there. That is going to be a really huge infection control issue that you have with that. So you're going to want to get those reupholstered and to protect your patients as well. Diane, do you have anything on this particular room besides what I just said?
I think so. Just everything has to be able to be adequately disinfected and disinfected per the manufacturer's instructions. So I concur with what you said.
Okay. And Kate, do you have anything?
No, I'm good. I just want to make sure that the people cleaning that table know the wet time of the specific disinfectant that they're using, because they run from 30 seconds to 3 minutes. And if you put that paper on too quickly, all you're doing is sucking up the stuff and not disinfecting the table. And lastly, I just spoke to somebody this morning with the torn table. The greatest place to go to is car leather shops, repair shops. They will be able to fix that table at a much less expense than buying a whole new table if you can't disinfect it, if it's ripped or torn. Okay, and we do cite that, so we see that.
Yeah, I've seen that in a bunch. I've told a bunch of people, you need to go to the car. I remember you saying that. It's like, go to the upholsterer, the car place, and they'll upholster this for you. So very reasonable.
We have those places even in rural.
And I guess the CPA sort of OCD in me is really bothered that this thing is not centered correctly as far as the paper.
Me too. I want to fix it.
I'm bothered by it. So laboratory, we're getting close to the end here. We're getting very near here. So here's our.
We have a question, I think.
Oh, go ahead.
Mark, you had a couple questions for the exam rooms.
Okay.
Two of them came in and asked, why is there an issue with dial soak? Because I think Kate said that she didn't like it.
Read the label, see what it'll kill. That's what I would do. I would look at it and see what it would kill. It's not a good disinfectant, I don't believe.
And then we have one comment that says, I guess plumed eye wash stations must be checked weekly running for 3 minutes. We keep a log for all departments. Our hospital was cited for this from the Joint Commission.
Hospital.
Okay,
That's
so
a
3
hospital
minutes.
reg. Yeah, good though. Good information. Good information.
Thank you. Because I've seen different numbers on there. So
And that's all the ones that are related to the exam rooms for now.
Okay, let's move on. Let's see here. Here's our laboratory, and let's move on to the next one here. 6 required lab services. You have to have the ability to do these 6. Actually, there's 5 lab tests, and then there's primary culturing to send out to a certified laboratory. Again, you got to follow all of your manufacturer's guidelines for keeping preventive maintenance on the clinics or on the lab equipment. Competency, that is something that we've got written up several times. Your lab people is doing some type of testing or verification of competency. Diane, can you give me a little bit of more information on that one as far as what you can do to prove competency for your lab people?
Yeah, absolutely. Almost all of these, the equipment and the supplies, if you talk to the website, not to the website, you can't talk to a website, but if you go on the website or talk to the manufacturer, almost all of them have a small competency checklist that you can utilize. And it's really, you just want to make sure that they're doing, that we know the steps, and we know, especially when maybe a new test comes in, we need to make sure that just because we did it a certain way on an old piece of equipment, it may not be the same on a new piece of equipment. And you've got to be able to not only perform the test, but, be ensured that the diagnostic information you're getting is correct, because it helps you treat your patients. So I think that's super important. And then so that supervisor, whoever, if it's a provider or a nursing supervisor, whoever it is going to check, watch someone perform it and then give written documentation that they know they're checked off.
Okay. Kate, do you have anything?
No, I would agree. These are wave tests for a reason. There's very low chance of error, but you do want to make sure someone knows how to do it, to Diane's point. Very important, particularly on the hemoglobin hematocrit. There's a machine involved here. We want to make sure we know how to operate it.
Okay, perfect. All right,
and make sure your CLIA is current. Got to keep a current CLIA.
And remember too that you do preventive maintenance. You should have a listing of all of your equipment that's electrical, like your AED, your EKG machine. Make sure that every year that those are calibrated. Even if they're brand new, if you've never used a machine before, you still have to get them calibrated to make sure that they were working correctly out of the box. Typically, you can get a biomedical company to come out that's close to you and do this relatively inexpensively if you're an independent RHC. If you're a hospital, the hospital will come out and they'll put the little stickers on there and come out every year and do that as well. But that is a very important aspect of you passing this inspection as well. Kate, do you have any comments on that particular piece of it?
Well, just a very current comment. At this time, we have clinics that are unable to get people to come out right now. So if your inspection expired on April 15th and you can't get somebody out or they hadn't come, we will not cite you for that right now. You're just going to have to hold until they can come out again. And the other is to look at your manufacturer's instructions for use. There was a white paper a couple of years ago from the biomedical engineers that says we're paying for way too much of this. An ophthalmoscope has a battery. When the light bulb goes out, change the battery. End of story. You don't need to pay for biomedical engineering. So make sure you know that and be able to document it. If you didn't get it inspected, then you better show that piece of equipment. If it's a baby scale and it's self-calibrating, then have a log. And where you calibrated, whatever the manufacturer says, show who did it in the clinic, because it can be done in the clinic, the ones we've seen. I want to mention one other thing that's very COVID related, and I don't know if we're going to see that. The American Heart Association has extended all certifications for BLS by 60 days. and that's for if they expire during the COVID time. So that we wouldn't cite that either if your BLS is expired right now. If expired last year, that's not going to cut it. But if it's expired right now, they are all extended because we're not having the classes. We can't get people out to do the practice. I know you can do that online, but they have extended, and I have that letter if anybody needs that.
Okay. Diane, do you have anything on this?
Not really. I think it's all good information. Yep.
All right, perfect. Okay. Laboratory, one of the things we always talk about is clean and dirty, sterile, non-sterile, doing things in different places there. So, Kate, whose turn is it? Diane? No, Kate. It's Kate's turn to go first on this one. Kate, do you have anything on clean or dirty, or as far as laboratory goes?
Oh, it's right in our standards. It's very, very important to prevent cross-contamination. We want to know what's a clean area and what's a dirty area. If you put a piece of equipment down, you don't want somebody picking it up because it's dirty when it should be, or it's not clean, exactly, and it's put in the wrong place. We want signage on that. And if you have a very small clinic, as many are, you can literally put a tape down the middle of a counter and put a sign over here clean and a sign over there dirty and make that work. That's really very important throughout the clinic, wherever there's possibility of contamination.
Okay. Diane, you have anything?
And just like Kate said, I love that. You have to have a continuum of clean to dirty. So it looks in this laboratory like perhaps they have medication stored in that medication refrigerator. You know, if you're going to doing medication prep, so make sure that, because it's been cited before, I know Kate and I've seen it a ton of times, where they're kind of drawing up medications and there's urine and blood right next to it. And, you know, so we really need to make sure that if you can't have, like here, it's a great space because you have a counter that could be one that could be clean and a counter that could be dirty. But if you're sharing a counter, make sure that those, you know, all of those activities are quite separated.
Perfect. Okay, that's great information there. And then this one, I didn't really see. Diane, do you have anything on this particular picture? I didn't really notice anything from my standpoint.
No, I didn't. I think we saw this picture yesterday. I was looking at it, and you know, just making sure that they have the right level of CLIA certificate for the, you know, for what they're doing. Occasionally, you'll see some scope creep, and you'll have somebody that started doing wave tests, and now they've bought new machines, and you've kind of gone into a new level of laboratory procedures. So
yeah, that'd be a CBC machine right there. Kate, do you have anything on this one?
No, I'm good.
Okay, all right. Yeah, we're gonna have to go a lot more good. And then make sure you do your control logs. Even though we've had more people argue with me about, well, we're CLIA waived, we don't have to do control logs. So, yes, you do have to have control logs. You have to make sure, like Kate said earlier, was that your lab test is working correctly, that your people are trained correctly, and that you're getting accurate results. So, Diane, do you have anything on that?
Just make sure they know when quality control activities have to occur. You know, when we open a new box of supplies, or you have new control solutions. That's just the thing. That's the thing we see every once in a while. People just don't know when to do them.
All right, Kate, do you have anything?
Just make sure your controls are all in date. That's critical information. They forget that because may not be doing all those tests every time, and so we want to make sure they're not expired.
Okay, we're gonna move. Place hints. This is one of Kate's slides here. Place hints throughout the clinic, especially when you have processes that people tend to forget. Multi-dose vials must be labeled, and people typically use 28 days for the expiration date once punctured. Make sure you put those reminders out there to people. It's just so they see it all the time. So, Kate, this is your slide. Do you have anything else that you'd like to talk about when you're on this slide?
No, but I would add a new sign to this slide now, and it would say single dose vials are never dated. We're beating it to death, and we're still seeing it in clinics. Please, please listen to this. It is a condition level finding, one single dose vial with a 28-day date on it. There is no preservative. There's no way to know that medication is effective, if not even harmful to the patient, if you gave it 3 days later, 5 days later, who knows? There's no testing on it. That's why it's called single dose vial. Draw up what you need from it and throw the vial away. Everybody should know, you walk into that bedroom, you pick up a vial, you look at the name of the medication, you look at the dose, you look at this expiration date, and you look at the whether it's single dose or multi-dose vial. Lots of reasons it's happening. It's still happening. It happened last week for us. We don't want to ever see that again. We need to just keep saying it. It's the only thing I can think. So maybe I would add a sign to this that about single dose vials. Single dose
vial. Okay. Diane, do you have anything?
And on that, I'm just going to keep preaching to the choir. Single dose vials, a lot of people have a really bad preconception that they're the tiny vials and multiple dose are the large vials. Well, guess what? There are some vials like sodium bicarb that are single dose and they're large. So it's really a competency thing, making sure that your MA staff or nursing staff, because I've even seen it in licensed nurses, that they really don't understand the difference. So.
Perfect. Okay. Okay. Refrigerators, where they're storing specimens. I guess my biggest thing is have the specimens in one refrigerator and then have your other immunizations, your vaccines in another refrigerator, because again, you're getting cross-contamination there. So Diane, do you have anything on that?
Yeah, and absolutely. I mean, and I hate to say that I've really seen this. I've seen food in those specimen refrigerators. You know, we've seen it all, but it's a good, you know, just keep everything. Food goes in one, medications go in another, specimens go in another.
Kate, do you have anything?
No, just make sure you know. Are we going to? I think the next slide's about temperature. Biohazard is very important on the specimen refrigerator. There you go. So you have notification ones. You have ones that will tell you when the temperature changes. The most important thing to remember here is you go home at 6 o'clock Friday night, and if there's no Saturday hours, you're not back till Monday. That power went out Friday night late, and it might have come on Sunday morning, and you're in range on Monday. How do you know those drugs are safe? You must be able to answer that question. A couple of years ago, somebody named Mark Lynn gave me so much grief about generators. And he remembers that too.
I have a very nice question is for you, Kate.
No, you do not have to have a generated system in your clinic, but you have to have a way to handle power outages. That's really important. You must have full confidence that the medications are safe for your patients. That's the bottom line here.
All right, let's radiology. Do y'all really do a whole lot on X-ray machines when you guys are going in there? Kate, is that something? What do y'all do as far as that process goes?
It's mostly about safety. So we want to make sure that machine is calibrated to its proper timings. We want to make sure the person is trained to do X-rays. They must have a certificate. We're not having nurses run back there taking X-rays. They have not been trained for those settings. We're going to make sure there's proper shielding for patients, and we're asking every patient, female patient, are they pregnant? Could they possibly be pregnant? So that's the important things there. Of course, cleaning and whatnot, but that's the biggies. We see them on occasion. We do immediate care clinics, so we see them there more frequently than in the rural health clinics.
Okay. And Diane, do you have anything from your standpoint?
Signage on the door. Signage on the door, that's really important. And the number one thing that honestly I've seen in radiology and where they have ultrasounds is they sometimes will have a computer where they're doing patient information and doing things. And I've cited it, I know at least twice, that computer was not locked, so that patient information, it's different. I think sonographers and people that work in radiation, they don't think of that sometimes. So just making sure that you have HIPAA, regulation in there as well.
Okay, perfect. All right, we're going to have to move quickly because I don't want to go much over an hour and a half, and so we're going to try to get through this quickly. There's just a place where they're storing the film, and I didn't really see a whole lot in there. So I guess basically what y'all just said as far as that goes. Drugs and biologicals, this is storing the drugs and biological. There's a listing of the things that you should be doing. Again, and when you're giving sample medications to patients, a lot of people have started going to vouchers because you should be documenting who you gave it to, what the medication was, what the lot number, what the NDC number was. So in case that sample medication was recalled, you can contact that person. Is there anything else, Diane, on as far as this listing here that's important that we need to emphasize to our clinics?
So the one thing I would bring up that's about drugs and biologicals that just is timely, and I just saw, you know, you have to have a process to making sure that everything that you have is in date. You're not giving expired medications. I just saw that the FDA has released on their website, they have medications that are in short supply because of the supply chain disruption, that some of the manufacturers have gone in and given extended dates beyond their expiration date right now. So if you notice that you've got a medication that you just cannot seem to get it in right now and you're hesitant to throw it away, go onto the FDA, enter that manufacturer, buy that medication by the manufacturer, and you may have an extended date of expiration. So if a surveyor comes through and you've got something, you need to have, you know, shown that there's a process that we've looked at that, and this is why we have kept that medication available for use. And then also controlled substances at the bottom. We just really want to make sure that people understand how to identify if a medication is a controlled substance. Sometimes with sample medications like Viberzi, Lyrica, people will accidentally go ahead and put them in a sample closet and they're not secured properly, or they don't have proper record keeping that would be in line with the DEA's regulations for practitioners. That would be what I would say.
Okay, perfect. Kate, do you have anything?
I would add one thing. If you are state surveyed, and the CDC recommends nothing in the door of the refrigerator. It is not the same temperature as the body of the refrigerator. So they recommend putting water bottles, which we require, in that door. And we've had some state surveyors call that food. I don't know, they didn't. So if you are state surveyed, please label those bottles not food per CDC or something like that to keep yourself from a citation. We actually had that happen to a clinic. Unfortunate, but just in case.
Okay, perfect. Okay, here's where the drugs are stored. They're locked up so people don't have access to them. There's a little numeric lock there, so make sure that you do that. You want to keep that locked all the time, not just when the surveyors are there, but all of the time, so that people cannot just walk in there and just go shopping in there and pick something up, because you can't always watch the store all the time. So that's just a very, very basic thing. Every month you want to come in, look at your sample medications and make sure that there's no expired drugs. You want to document that that's the case. One of the best things that you can do is, this is Kate, she went to West Virginia, and they have this thing that Kate calls the West Virginia system, where they go through and put the color of the month in these little, they go to the Office Depot, they buy them some of these little stickers they put on there. January is going to be in red and February is going to be blue, and then you just put the year in there, and it's very visual. You can look at it and you will know exactly when something expires. So Kate, you want to tell them a little bit more about that process? I think I explained it, but you can add to it.
You did explain it. You explained it well, Mark. And the whole point is to save a lot of staff time, make sure all expired medications. So we're in what now, the 5th month. So if you go in there and you see yellow from April, if that's the way that's set up, then it's real quickly you'll know you have expired medications. And I want to emphasize, everything with a date is subject to the survey. So Telfa, iodoform, gloves, all those things have an expiration date on them. So it's not just this medication cabinet. When you do your rounds monthly, everything in the clinic that is expired needs to be pulled.
Okay, Diane, do you have anything?
No, I pretty much agree with that. And
Okay.
Locked up. Oh, wait. If a cabinet is supposed to be locked up, when we come by, it needs to be locked up. Your medications. We see that a lot. So.
Okay. And then here is, I think this is one of Kate's slides too. This is if people have autoclaves. Kate, tell us about the autoclave process, just if people are still using that. And
well,
maybe is COVID-19 sort of done away with that, or how does that work?
No, well, we still need sterile instruments when we need sterile instruments if we're not doing disposable. The important thing here is to hear this. If you have a tabletop sterilizer in your clinic, we can almost bet we're going to have a deficiency. And all you have to do is pull the manufacturer's instructions for use for that unit and read what it says you should do. What is the process for cleaning, maintaining, sterilizing instruments for that unit? And if you'll just do that and make sure you're living by that, of course, you should not have a problem, okay? So it's really that simple. And if you're sending your instruments to the hospital to be sterilized, which many provider-based clinics do, then train somebody on the staff to accept those instruments or not. On survey day, it's your deficiency, not the hospitals. We're not surveying hospitals here, only the clinic. So make sure those instruments aren't lost, that the packaging is dated or not dated as appropriate by their process, and that they're not torn, ripped, wet, the simple things that we all know about. Teach them how to do this. They should know that, because you want to have full confidence that you're handing a provider a sterile instrument to do a procedure. That's really very important. We cite this a lot.
Okay. And Diane, do you have anything besides the person beside this is barefoot in a medical facility?
Yeah, no, well, that's probably an OB-GYN clinic, but the one thing I would say here is this slide for me gives me great pause, because you've got something on here. You can see up at the top there is a peel pouch that's been put in there that has been through an autoclave process, where you can see the tape has black lines on it. But as you see, the other peel pouches have tape that don't have black lines on it. That would make me the hairs on my neck stand up, and I would really start looking at their process and interviewing people, because what I see in that are instruments that have been pouched. They've probably been cleaned, but it doesn't look like they've gone through thermoprocessing that shows me that they have been effectively sterilized. So that for me would be something I would start paying a lot of attention to, and that would be very problematic. So.
Yeah, I think that, and that's why I said, when I first said, can we still even do this during COVID-19? It's almost getting to the point to where you're gonna, and I think what Kate said about the autoclaves always getting written up. Every time I see an autoclave, I just like, oh no, it's gonna be bad. So if you can start going to single-use instrument, disposable instruments, that's probably in a post-COVID-19 world, that's probably the safe way to go.
And competency, that's the thing. I mean, you've got to make sure who's doing it is competent to do it.
Okay. And Diane, what about oxygen here? And we're going to talk really fast on these. So should they have it chained to the wall and keep, my understanding on oxygen is you want to try to keep it chained to the wall, and you want to keep the ones that are filled and are half filled, you want to keep them sort of separate. And if you have empties, you want to sort of keep that separate. So Diane, what is the process on oxygen?
So there's a couple of ways that you can safely store an e-cylinder like this is. That is actually an appropriate way of storage. It is a cart where it's stable. You could have it to where it is chained to a wall. You could have it in a milk crate. There's not a real milk crate, but they call it a milk crate. But we want to make sure that in an emergency, we know which ones are full and which ones are in use or empty. So they should be segregated. We don't want to find out when somebody has passed out that we've got an empty tank. We want to have the supplies necessary. The supplies necessary to deliver oxygen in an emergency, that people know how to utilize it. So those are the big things for me.
Okay. And Kate, do you have anything? Hello, Kate. Okay.
Oh, she's lost.
We may have lost her, or she may have to step out because we are running so long. Danny, open up this. R8Cs are required to maintain snake antidote, yes or no? And Diane, I guess I'll stick with you on this one then.
I take more.
Are they required or not?
They are not. There has been guidance that happened after January, in January of 2018, when the interpretive guidance was updated. We've now had new interpretation that says you really just need to look at what is required in your community, the emergencies that you normally see in your patient population. So there was clarification that was put out in a certain survey letter just recently. I believe it was in September of 2019. And then I apologize, Mark, but I'm going to need to disengage, and I know that Kate and Elsie are going to be able to. But thank you so much for allowing me to participate today. It's been wonderful.
All right, Dan. Thank you for everything. We really do appreciate it. We're starting to lose people. I didn't realize how long it would take. Danny, our question? How did we do on our question?
90% said no and 10% said yes.
Okay, so yeah, the answer is no. You're not required to have it. These rules that changed that Diane talked about in September said RACs could consider the following. Here's the question. Next question. RACs should consider which of the following when stocking their emergency kit: A, the community history; B, the medical history of its patients; C, accepted standards of practice; or D, all of the above. And then the answer, I don't know, Kate, are you back on?
I am. My phone just decided to stop, and I couldn't hear Diane's last answer on that oxygen. The answer is all of the above here. All of the above.
That's right. That's right. It's all
our process. Our process was approved this way from the beginning. This is how we've done it from the very beginning. The only issue, we had some states that required more, but from the federal government, they approved our process just this way.
Okay, perfect. Okay, and then Danny, what was our answers on this one?
91% said all of the above.
Okay, perfect. Okay, that's good. That is good. And then here's where you would store your medications here. You don't have to have this big, huge medication box like this. A lot of times we just tell people was go out to Walmart and buy you a tackle box and put in that basic medications that you need in using the criteria that we just talked about. If you're in Claxton, Georgia, which is the rattlesnake capital of the world, well, you may need, some snake antidote. But if you're somewhere else where there's no such thing as those snakes, you obviously are not going to need that. So think about what the community that you're in as far as your storage of emergency medications here. And we'll move a little bit quicker just to get through this with you guys. Here's the Appendix G where it talked about that. So this is where we got our information there. So we just didn't make it up. And here is a document that's from the NARHC where they talked about how that this policy was relaxed. The actual policy, and sometimes you'll get this not from Quad A or not from the compliance team, but a state inspector. They have something called a CMS 30 form. And that CMS 30 form was last updated on May the 1st, 1978. So they will ask you for some weird things, like they may even ask you to be able to do a pinworm, or the nurse practitioner be there 60% of the time. And so if they ask you something like that, just call Danny or myself. There's actually an RHC fact sheet that if you show that to them, it's about 9 or 10 pages long. That will get that surveyor back in the right direction on emergency drugs and biologicals there for you guys. And then this is my one for Kate here, is RHCs must have a generator for emergency power. A, yes, or B, no, because I did get a little bit sidetracked on when TCT first came out, when y'all first became a deeming authority. I misread the last policy in your TCT policies there, your guidelines there. I was thinking you were telling people you had to have a generator for emergency power, and of course you didn't, but you do have to. Like you said, Kate said, there's a process that you have to go through to ensure the safety of your vaccines, your immunizations, and protect them in case of power failures. So Kate, you want to talk about, I think we talked about that earlier, but if you want to say any more about it.
No, I think we're a little short on time. We're good. We're good.
Yeah, we're good. Yeah, we're running out of time, and I apologize. I'm always taking too much time, I think. So what was our answer on this one, Danny?
91% said no.
That's right. That's right. You don't have to have generator power. There are grants out there. So if you can get a grant, especially now, if you're in the Southeast and you've got all these tornadoes going on, it is not a bad idea to get a generator with power. If you don't have a backup generator for your drugs and medications, make sure that you've talked to the hospitals or the local health departments so that you have a place to store those medications if the power goes out. So there's the revised Appendix G, September 3rd, where they actually tell you about this stuff. So let's go through. There's a place where you can click into that and see the revised. That's actually the interpretive guidelines that came out in January of 2018, I believe. There's this like 93 pages. So if you want something to put you to sleep, you can read that. Questions and comments. We've gone way over time, so we're not going to do any more questions. We appreciate so much Quad A for being here. We appreciate the compliance team. Kate, thank you so much. Thank you, Elsie. Diane has had to leave. Amanda, Tom, thank you guys for doing this. I think it's been extremely helpful. I know it's been helpful to me to understand some of these things, and I'm sure it's helpful to all of you people, especially if you're waiting on. I know we've got a lot of new TCT and a lot of Quad A clients that are waiting for their inspection. So I know this is going to help them to do their self-survey. So Kate, do you have anything before we go?
No, just know that we're here for you, and we are actively working on surveys, and we hope to see you soon. Thanks, Mark.
Elsie, do you have anything?
I will echo what Kate said, and we're working on surveys, and I'll be seeing several of you soon.
Okay. All righty. Well, Amanda, do you have anything before we go, or is she still
No,
around?
just thank you again.
Yeah, thank you. I think it's been very helpful. Like I said, I've learned a lot, and I know our people have learned a lot too as well. So I'm going to go ahead and close out the webinar. Thank you all very much. We'll have all this stuff posted for you. So if you want to see it again, or you want to give it to some of your people, it'll be available. So thank you all very much, and we will talk to you.
Thank you. Thanks, everybody. Be safe out there.
Bye, everybody.